Okay. Second. Sorry. Just we have a quorum here. Seconds and we'll get going. Been a few weeks since we had EP conference, various strikes and national holidays and things. So, all right, why don't we get going? Okay, this is an RAO projection of an EP study in somebody who has SVT, and I would like you to name the catheters. So I'm going to, why don't we start with Dr. Marshall? Dr. Marshall, can you name them from 1 to 4?
Sure, sounds good. Good morning, everyone. For starting with number 1, is going to be our right atrium catheter.
Mm-hmm.
Number 2 is going to be the HIS catheters, and you notice with the how it looks different from 1 is like the 2 pairs. And then catheter number 3 is our coronary sinus, which again, then you'll see the 5 pairs. And then number 4 is the right ventricle.
Right. So one thing very good. Thank you. One of the things that I'll mention is that the RA catheter is also a quadrupolar catheter. In other words, it has 4 pairs. It's just that we're looking at it on FOSS, and so we can't see all of the pairs. And the reason for that is one of the pairs we're using to pace, and one of them we're using to record. And so that's why we put a quad in. Now, for the HIS catheter, we could put what both Dr. Love and I do is we record from 1 to 2, from 2 to 3, and 3 to 4, so that we have 3 HIS deflections on the intracardiac recording. Some laboratories will actually put a hexapolar catheter and have 3 separate ones. Some will even put in a decapolar and have 5. But yes, that's correct. This is the HIS catheter sitting across the anterior tricuspid valve annulus and the coronary sinus. Now, here we are in the LAO projection. And why don't we ask Dr. Condon, can you name the catheters looking at them in the LAO projection?
Good morning. So is look, 3 is the coronary sinus.
Yep.
2 the HIS.
Well, yep.
And
Excellent.
then 1 is maybe the RV maybe.
The RV, right? Exactly. Good job. So when we're looking at the mitral annulus on LAO projection, we think of it as sometimes when we're describing where we identified an accessory pathway to be, we're thinking about the annulus as almost like a clock face. And some people in their reports, and I often will do this, will comment on where on the clock face, if you were looking on the LAO projection, it was the pathway. So for example, if the pathway were at this pair, which would be the coronary sinus 3-4 pair, meaning 1, 2, 3, 4, we would call this, might say 3 o'clock on the mitral annulus, for example. So this is just how we project it. And on CARTO, we see it the same way. It's unusual these days to see a fluoro image of this because everybody is using CARTO mostly, but this is the traditional way that we used to look at things. And there is no RA in this particular projection or this view, because in this case, we did an ablation of a left-sided pathway with 3 catheters, just coronary sinus, Hiss and actually, I'm wrong. This was actually for the same case. It's just we cut off the RA catheter, which is probably this catheter here. Sorry. Okay, let's move on. All right, this is a tracing on a patient in the unit a couple of months ago, weeks ago. And my question to you is, what is happening here? And why don't we go to Dr. Potpourri, our soon-to-be cardiology fellow.
Good morning.
Morning, Mahmoud.
So I see initially the heart rate is going to be around almost like 150.
Mm-hmm. Yep.
And I could see the QRS complexes initially, I would say from telemetry looks a bit wider. But then
Yep.
I can see like I can see P waves, like clear P waves at the beginning. But then I can see like P waves, like a change in the QRS morphology, and then a P wave, and then goes what looks like a sinus rhythm. I can't comment without an EKG, like a 12-beat EKG. But then it turns out like to be the P wave was consistently seen for the rest of the lead, I would say.
Okay. So
Could
you're
it be?
go ahead. I'm sorry to interrupt you. I apologize.
I'm not sure if initially it was like some kind of a ventricular rhythm, and then that switched into a sinus.
That's exactly what that is. You got that right. So what we have here, which is a very nice tracing, is although maybe not the nicest, it's a little hard to read, but what we see here is that we have a wide QRS rhythm, and then we have a narrow QRS rhythm. And then actually in the next strip, the same thing. These are not simultaneous. They are continuous. So I don't think, or maybe they are. Are they simultaneous? Maybe they are. Anyway, it doesn't matter. So we start wide and then we become narrow. Now, and you're right, we do seem to have P waves, right, before each of these wide QRSs, and then we probably have P waves before the narrow ones. So what this is basically a ventricular rhythm that has a very similar cycle length or heart rate to the sinus rate. And this is a nice example of automaticity. And I think that if you measure the R to R interval on these beats compared to the R to R interval here, you'll notice it's hard to do on a PowerPoint here, but this R to R is ever so slightly tighter or faster than this heart rate. And so basically what's happening is this is a beautiful example of how when it comes to heart rhythm, whatever is fastest usually wins. And so we start off in this wide VT or accelerated ventricular rhythm, and then the QRS narrows because the sinus rate is ever so faster than the ventricular rate. And basically what's happening here, it looks like these P waves are conducting, but really what this is isosynchronous beating. And you could probably notice that there's this ever so slight narrowing in the QRS until it becomes this narrow complex here. And that's because what's happening is as the sinus rate is ever so faster than the actual ventricular rate, this is like these two beats are like fusion beats between the conducted QRS and the accelerated ventricular rate. And then eventually the sinus rate is just fast enough that the patient is now in sinus rhythm and not an accelerated ventricular rhythm. And so this is a very nice example of somebody who had an accelerated ventricular rhythm. And in this particular case, the patient had myocarditis. And we can see in myocarditis many different types of arrhythmias. The most common that we think about traditionally is that of heart block, which we see sometimes in people with myocarditis, but this is an example of somebody who had ventricular tachycardia in the setting of myocarditis. And So I thought it was a nice tracing, and an example of how this is clearly an accelerated or automatic focus. And here we have the same patient. And Maya, what do you think is happening now in this patient?
Okay, morning.
Good morning.
So looking at the tracing, so it looks like we see some wide QRS complexes and some that are narrower and look a little bit different. Although I do see P waves before all of the QRSs.
That's
I
right. So
think.
it's a little confusing, right? There's a P wave before each one, and yet the QRS is not the same for all the beats, right?
Yeah. So I guess I wonder if some of them are being aberrantly conducted in, I guess we're getting like 3 wide to 1 narrow almost.
So what is the setting where people usually aberrate? So you're right, you can have conduction with aberration that causes a widening of the QRS, but when do we normally see aberration in an otherwise healthy person? When would you see someone have aberration?
I guess you can see that in like WPW when you have an accessory pathway.
No, that's not aberration. That's just pre-excitation, right?
Okay.
Somebody.
Right.
But aberration, remember, is when there is slowing of conduction in the His-Purkinje system or in the AV node, causing a widening of the QRS. So normally, we would expect to see aberration in someone who has a fast heart rate, and oftentimes in a suddenly fast heart rate. A classic example might be at the beginning of an episode of SVT, we sometimes will see a couple of wide QRS beats before it narrows. But in this case, the heart rate is pretty much the same, right? The R to R interval is only ever so slightly faster or slower, but not big differences, right, from R to R. So, and remember that this patient, I'm saying same patient. So this is the patient that we just looked at with Mahmoud, and now this is the same patient. So how would you explain? So we know this patient has a history of an accelerated ventricular rhythm.
So maybe the, like we were saying, whichever conductions, whichever conduction tissue's intrinsic rate is faster will take over. So I guess like the ventricular rate and the sinus rate may be kind of approximating each other, and from beat to beat, one is faster than the other.
That's exactly right. So what we're seeing here is that this is like a little competing automaticity example where the sinus rate and the ventricular rate are very close to each other. And one of the interesting things you see is that on the wide QRS beats, you notice that the PR interval is different than on the narrow ones. And that's because those P waves are probably not conducting or are only marginally conducting, right? Like look at this PR interval versus this PR interval, okay? So these are 2 beats where and you notice also this RR interval is just a little narrower than say the interval from here to here. So this is an example of the sinus node and the ventricular focus basically competing with one another as to which is faster. So Maya, if you're going in and out of this rhythm, what could you do? Like what therapeutic choice could you make to try and stop this? First of all, but let me take a step back. Why would you want to stop this? Does this matter, or do we need to stop this?
Well, I think in the short term, if the patient is hemodynamically stable, it might be okay, but you wouldn't want to leave them like this for too long.
I agree. So in the short term, you would assess the patient's hemodynamics and see if this rhythm is really having a negative impact on the patient's hemodynamics. Does the blood pressure change? Is the patient having a lower urine output? Is the lactate level rising? Are you acidemic? Things of this nature. So that would be sort of a rationale for potentially intervening. So if you got, you're on call and you got 500 phone calls about this patient going in and out of this rhythm, and it seems like in the wide QRS, the blood pressure is about 20 points lower. So they really would like you to get rid of these wide QRS beats. So what would be some of your options?
Well, if this patient was post-op and had pacing wires, you could atrially pace them at a rate that's slightly faster than the ventricular rate.
That's absolutely an excellent suggestion. Yes, you could pace on the theory that whatever is fastest wins. And so if this rate is about 150, you could pace in the atrium at 160 and potentially suppress this. But I'll remind you, this patient has myocarditis and does not have wires. So you don't have that option. But if it were a post-op patient, I agree, that would be a very reasonable choice. Although, again, I want to caution you that although you would suppress the ventricular ectopy, you don't really know if paced at 160 is better than this rhythm at 150. So you have to, when you turn on the pacemaker, of course, as I'm sure you always would do, you would want to look at the hemodynamics with the pacing. Sometimes you're surprised that even though you have suppressed the ventricular ectopy, actually the hemodynamics appear to be worse. I would expect they'd be better, but sometimes you could be surprised by that. Okay, so if you had wires, you would pace. That would be a very simple approach that would avoid the need for pharmacology and such. But in this case, let's say we don't have wires. So what would be a next option?
I guess we can see if the patient, I guess we would, want to help the sinus rate get faster than the ventricular rate. So if we're on any drugs that may be slowing the sinus rate, to try to wean those if we can, like if we're on Precedex or if we're on, I don't know, like beta blocker or something, just try to wean those medications.
Okay, that's one possibility, although a lot of those agents might work more on the VT anyways, but yes. I mean, this isn't so much an example, right? The atrial rate is like 135. So it's not that the atrial rate is too slow. It's really that the ventricular rate is too fast in this particular case, right? But what else could we do? Are there any medications we could consider using?
That's what I'm trying to think of.
How would we treat VT?
I guess we could use like lidocaine for VT.
Yeah, we could use lidocaine. That would be a very reasonable choice. Could give 1 per kilo of lidocaine and then start a drip and see if that affects the PVCs. That's one option. What other agents can we use that would be a reasonable choice as well? But lidocaine is a very reasonable one.
I think
nice thing about lidocaine also is that we'll see the effect very quickly, usually within a few minutes. Procainamide, yep, you could use procainamide. Typically, we would give a total of 10 to 15 milligrams per kilo, usually in 5 per kilo boluses, see what the effect is, and they can put the patient on 20 mics. Yes, so you could give procainamide. That's always a good option. And then any other options besides those?
I think flecainide. Not flecainide.
Flecainide might work, but in a very sick heart, I think we would, very inflamed myocarditic heart, I think we would try to avoid flecainide just because of the slightly higher pro-arrhythmic potential of that agent. I think it wouldn't be a first-line agent. Also, it has to be given enterally, and in a sick patient, you might not have that option. The last one, of course, would be amiodarone, right? You could give amio. Okay. Amiodarone can be given IV. And in a teenager, which is what this patient is, you could give amiodarone and the benefit is we don't have to worry quite as much about cardiovascular collapse, right? That's really an issue for infants, not so much for older patients. Yes, there are other side effects, but generally speaking, amio would not be an unreasonable choice in this as well. So, and actually, I would probably do it in the exact order that you did, which is I would probably start with lidocaine. If that was ineffective, I might try procainamide, and then I would probably go to amio. And the hope would be that if this is myocarditis, that the inflammation will resolve and hopefully the arrhythmia as well, but don't really know that for sure. So, any questions on this case? Okay, let's move forward. All righty. So now we're looking at a 12-year-old with palpitations, and this is a Zio patch recording obtained from 12:56 a.m. And I'm going to ask Dr. Bebbia, what does he think about this tracing?
Good morning.
Morning.
So it looks like if the P waves are conducted, that there's a first degree heart block, at least the PR is long, and then actually now it's second degree because PR is prolonging, and then we see a skip beat basically. So second degree Mobitz 1.
Right. This is a Mobitz 1 second degree block. And the other nice thing is you always, when you have a slow rhythm like this, when you see grouped beating like this, that's very characteristic of patients who are having, what do you call it? Mobitz 1 heart block or type 1 second degree block. Now, anything you should do about this? What are you worried about this? You're going to report this, obviously, in your Zio patch or Holter recordings notes, but is this a concern?
Well, you mentioned that it happened at night when I assume the person was asleep. And I think, intermittent Mobitz 1, that can still be considered normal when person sleeps. So as long as we don't see any higher degree of block. So let's say if we only saw this once during the night, I guess I would not treat it, maybe just, get a Zio patch again sometime later. But if I see any higher degree of block, then it would be concerning.
I think that's generally right. I mean, the key is really what's going on the rest of the time, right? Is this patient doing this during the day when they are presumably awake? Or is this only occurring when the patient is asleep? So if we find this on a Zio or a Holter, or we see this on telemetry, we're not especially worried about this. Although the PR is notably long, so I'm going to guess this patient has first degree heart block in the baseline state, but I'd want to see some tracings when the patient is awake. But this could all be related to high vagal tone associated with sleep. Have to see really, but generally this would not get me too worried as long as the rest of the Zio or the Holter shows normal conduction. Okay. All right, this is a heart rate trend from a patient who had a Zio. And my question to you, this is, I guess, 2.5 days of recording. So my question to you is there anything wrong here? And if you were going to guess, could you posit a possible form of congenital heart disease that would be associated with this type of finding? So I'm going to ask Dr. Barris if he has any thoughts on this.
So I'm just looking first at the overall heart rates that are reported on the right, and I see that we have a minimum of 42, which would be something potentially wrong. we see only goes up to a max of 91. And even for an adult patient, I feel like a max heart rate over several days should be higher than 91.
Right.
And then I'm kind of looking in the top left corner, and I'm just looking that in terms of under day 1 and 2, it lists whether there's VT, SVT pauses, nothing that was alarming on the ZO. So mostly, I would think this is sinus node dysfunction. And then in terms of what CHD, post-Fontan patients might have sinus node dysfunction. I guess also heterotaxy patients might have sinus node dysfunction. Yeah, and since there's no, I mean, I would have thought maybe like this is a congenitally corrected TGA patients, but it's not registering as any heart block. So I think I'll leave it there.
Right. So a CCTGA or an LTGA patient would normally have heart block, but their sinus node should generally be working normally. So yes, I agree 100% with you, David. Excellent. This is someone who has sinus node dysfunction, right? We would not expect somebody's maximal heart rate. The minimum heart rate of 42 is not particularly worrisome. Healthy young people can have their heart rates in the 40s when they're asleep. We don't get too bent out of shape over that. But the fact that the heart rate, look at you have to always, when they're giving you the heart rate range over 24 hours up in the left panel, you have to look at the legend here. And in the y-axis, all of these heart rates are just between 50 and 100. And this is weird, right? There's nothing that exceeds about 90, 92 beats per minute. And in fact, we see here the maximum overall was 91. So that's notably strange and is a good sign of sinus node dysfunction. So I agree with you 100%. In the present era, the Fontan patient would be the most common patient to see this, although, we talk about Fontans having sinus node dysfunction, but I think we're basing that on the older Fontans, patients who had an old style Fontan or patients who had a lateral tunnel Fontan. It will be very interesting over time to see what happens to sinus node function in patients who have extra cardiac Fontans, where there is presumably a lot less surgery, a lot less suture lines near the sinus node. Will this type of a pattern still be seen in Fontan patients, say in another 10 years? Because remember that the sinus node dysfunction you see is typically a progressive feature, and we really are only now getting long enough out from initial extracardiac Fontans to start being able to compare, I would say, sinus rates from the past to today. But a Fontan would be a most common. Other one that you would think about, particularly in the ACHD world, would be someone who's had a mustard or a Senning repair. If somebody has, and in the present era, we would still potentially do that operation for somebody who has corrected transposition and is having a double switch operation. So that is definitely a potential concern of those patients. In fact, if you look at those curves of percentage of patients in sinus rhythm following a mustard or a Senning, virtually 100%, about 15 years out, essentially nobody is in sinus rhythm the majority of the time. So this is clearly suggests somebody who has congenital heart disease and is a post-op patient from congenital heart disease. Any questions on this, Tracy? All right. This is a 14-year-old who had tetralogy of Fallot repair at 6 months of age. Is there anything wrong with this tracing? Anything concerning about this patient? I'm going to ask Tarek, what do you think?
Okay, so looking at the tracing, and then I think three. So I think the fourth beat, there is what looks like maybe a PAC.
Well, what do you make of the PR interval in general on this tracing, on all the beats? It's kind of hard to see the P waves, I realize. But you can see here's one here, maybe there's one in there, sort of something that looks like a P wave here.
Yeah, so I think the PR is long, which, and let's see.
So what's another way of saying the PR is long?
So yeah, it's a first degree AV block, and I don't see any dropped beats. Looks like every P wave is followed by a QRS, so first degree AV block.
Right. And what do you make of the QRS duration?
Yeah, it's also, so the QRS duration is long too, but that's something that can happen after a TET repair, like you have a right bundle,
Right.
branch block.
So this patient has sort of multiple levels of block, though, has first degree heart block, which we believe is usually in the AV node, and has, you know, some bundle branch block here. So this would be, you know, this is clearly somebody who sustained some sort of injury to their AV node during repair of tetralogy, which is kind of unusual. We don't usually see that after a TET repair. Do see a bundle very commonly, but not usually first degree block. So this is a type of patient who we would really need to keep an eye on over time, just to, you know, because this could be progressive with aging and fibrosis and what have you. A little bit worrisome, but not worrisome enough to put a pacemaker in. This does not meet any criteria for a pacemaker, but it is certainly something that would be concerning. Now, if this was happening, you know, for the entire life of the patient since the time of repair, you'd be less concerned. If this was a new finding, you'd be more concerned. And anytime you see new first degree heart block, right, you'd want to look for things like hypothyroidism or myocarditis or inflammatory diseases of the heart that could be associated with AV nodal slowing. But I think in this case, one would just watch. One of the things I want to mention here is you notice that the tracing is kind of not that clean, right? You see a lot of artifact and all. This is one of the disadvantages of these types of patch recordings of holters. You know, we do a lot of these here at Mount Sinai because, well, there's multiple reasons. The most important is that patients generally have far greater compliance with these because there's no wires hanging and there's no additional device. It's all self-contained in the patch. So the level of compliance is very, very good with these devices as opposed to holters where it was very routine that 8 hours after you place the holter in the clinic, you'd have no recordable information, either fell off during sleep or the patient took it off, particularly with kids. So we sort of sacrifice quality of tracing for volume of tracing when we use these monitors. I think on balance, this is a fair trade-off because you can basically see what's going on here. It's not bad. There are different brands that suggest that they're better at their quality of their tracing, but the bottom line is at least we have a tracing. This, you know, normally by the 4:30 the day after the replacement, it would be gone. Okay. This is a tracing from an EP study in which we are doing some testing. This is at the beginning of the study, and the patient has a history of SVT, and we are rapid atrial pacing. And the question I have is, what has happened here? And why don't we ask Molly if you have any thoughts on this?
All right, give me one sec here.
Take your time. Just for the audience, we have four EKG leads, ECG leads. We have the ablation, which has nothing on it because we're not doing anything with it at this point. We have the high RA, which is in red in our lab. We have three. We already talked about how there are 3 pairs of the His, distal, mid, and proximal. We have 5 coronary sinus pairs, and then we have the RV. And at the bottom, it's just telling us when we are stimulating. Every time you see an S1 or an S2, it's the patient is being paced. And in this case, we are pacing. And someone was nice enough to measure the P to P interval at 320 milliseconds. So what is happening? It's really this beat is what I'm asking about.
Yeah, so we're seeing
you get
their,
this?
sorry, what'd you say?
All I was saying is, remember, we're rapid atrial pacing.
Right, so we're rapid atrial pacing, and then after that beat there, you're not seeing like ventricular, yeah, so you're having like a pause there. So I don't, is that what you call like an echo beat or?
No,
or
what is
you're
it? What happens when you get faster and faster and then you stop conducting?
Oh, you've hit wanky.
That's right. And
Yeah.
this is what we're seeing here. This is the Wanky box cycle length. Okay, so we see here, and this is just like the tracing that Sergey looked at from sleep, except we're doing it in a patient with rapid atrial pacing. So we see the AH interval, and then this AH in your mind's eye looks a little longer than this AH, and then this AH is even longer still than this one, or certainly if you compare this AH to this AH, we see it's longer. And then we capture the A, but there's no H. And of course, as you said, there's no V. So this is an example of Wanky Bach. And the patient is Wanky Baching at cycle length 320, which in a child under anesthesia is a reasonable Wanky Bach cycle length. Really, anything less than 400 milliseconds or a rate of 150 would be considered under general anesthesia, especially in a teenager, to be reasonably normal AV conduction under anesthesia. So this is an important test that we would do both at the beginning and at the end of an EP study, right? Why do we care about it before and after the ablation in a patient, Molly? Why would we test it before and after?
You're trying to see in someone who you're suspecting has another means to go into the SVT. You may not see you may not achieve Wanky Bach because it's able to conduct down the other pathway. And versus when you do it after, you want to see that you've achieved Wanky Bach after your ablation. I mean, you want to see that you've achieved it. Because if so, then you're achieving block at your one means of conduction.
Well, you're talking about if someone has WPW, right?
Mm-hmm.
So, right. But if they don't have WPW, why does it matter what rate the patient Wanky Bachs before versus after? Why are we checking Wanky Bach afterwards?
Also checking like the health or the degree of their function of their AV node.
Right, because we're taking things like toxic ablation catheters that burn at multiple hundreds of degrees Fahrenheit in somebody's heart, and we want to be sure that we haven't caused an injury to the AV node, either from the ablation itself or from maybe sometimes just the His catheter sitting near the AV node can cause a traumatic injury to the AV node. Or the back of the RV catheter can cause injury to the AV node, or really anything inside the heart that's not supposed to be there can cause injury to the AV node. So we always want to know at the end of the procedure that the AV node looks okay before we pull catheters out, because we want to make sure the patient is safe without having an RV pacing catheter in place, and want to know that we didn't cause an injury. So, you know, if we're conducting 1-to-1 at 320 before the ablation, and if the anesthetic technique is unchanged throughout, that patient better conduct at 320 at the end of the procedure, at least as well, and hopefully not worse, and hopefully maybe even a little better. So that's the most important reason we're testing before and after, is to make sure that the AV node hasn't changed as a result of our intervention. Any questions about that? Okay, so if that's the case, I think we'll stop today. Thanks so much for joining, and see you next week on Monday. Have a
Thank
good
you,
day,
Dr.
everybody.
Bess.
Thank you.
Thank you.